Hello, everyone, and a warm welcome to today's edition of Podcast. Today is July 19th, 2022, and I am Rifat Manan in California, and I am remotely joined by my good friend Emilio Madrigal, who is in Boston. Today, we are delighted to welcome back Dr. Fausto Rodriguez, who is Professor and Chief of Neuropathology at UCLA David Geffen School of Medicine, and he is going to continue his talk on the WHO classification of CNS tumor update, and this would be the fourth update. And today he is going to cover embryonal tumors. And before I pass on to Dr. Rodriguez, I just want to let our audience know that this lecture is accredited by City of Hope for one CME credit, but this credit will be available only during the live lecture. So make sure that you send the code only when it is during the live lecture, not later. And I will share the code towards the later part of the lecture. And how do you get the CME credit? So if you have not, you should go online and create an account at the City of Hope CME Center. You can see the web address here. And during the live lecture, so if you are in the United States, you can actually text the code to this phone number as you see on the screen. And if you are joining from somewhere outside of the United States, to our international participants, you can actually email the code to this email address, that is cme@coh.org, and make sure that you have to create an account first. And with that, I pass on this microphone to Dr. Rodriguez, and thank you for joining us today. Over to you now.
All right. My pleasure here to be online with everybody again. Very excited to discuss some embryonal tumors this morning. Let me. Okay, can we see my screen?
Yeah.
All right. So today we're going to talk about embryonal tumors. Just to clarify, we're calling these updates. These are not really official updates, you know, from the WHO or any committees or anything like that. It's just I'm updating, just in a sense, in an educational manner, trying to, you know, share some cases based on this current WHO classification that we are still all learning about and how to practically apply it. So these are personal updates rather than official updates from the WHO. Just wanted to clarify that. I have nothing to disclose. And here's some of the disclosure, All right, so this is the classification of CNS tumors, the section that pertains to embryonal tumors. If you can see, medulloblastoma hasn't changed globally very much. There are many different molecular subclasses that are used sometimes now for clinical trial enrollment, etc. But these are the major categories that we are responsible for as pathologists for the most part. These were essentially present in the previous classification. There's still room, as you see, for a histological defined category, which I like. And then there are other CNS tumors. Some of these have been present in the past. You see now new entities added, cribriform neuropathological tumor, CNS neuroblastoma with FOXR2 activation, and CNS tumor with big or internal tandem duplication, which we're gonna discuss through the presentation. Let's go straight to the cases. The first case is a 9-year-old boy that had worsening headaches, nausea, and vomiting. Very typical history for patients with posterior fossa mass. As we know, posterior fossa mass the posterior fossa is an area, is an anatomic compartment that is favored by tumors in the pediatric population. And here you see a large mass that was actually filling the fourth ventricle and compressing the cerebellum, which explains some of the symptoms. So I'm gonna go for the slide now. And this is the histology, the permanent sections. I move around a little bit. Right off the bat, we know that this is a malignant neoplasm, very cellular, primitive appearing. You do have some Mitotic figures here and there that are frequent. Vague nodular architecture, that's something that actually took me in a specific direction initially that I had to reassess. So yes, your typical round blue cell tumor, actually, you can see here a bit better that round cell morphology. I'm going to show you some stains. Some of the most important stains that we use for embryonal tumors, synaptophysin is very useful. It's a very sensitive marker for neuronal differentiation. And embryonal tumors, even though we consider them fully differentiated, we like to see some sort of marker for neuronal differentiation. And this is synaptophysin does the trick most of the time. So this is strong staining. There are other tumors that can have, even glial tumors that can have some synaptophysin staining, but when you have that morphology and this very strong uniform staining for synaptophysin in a pediatric population, you really are, it's very helpful, at least going in the category of embryonal tumors. That being said, then now we have a tumor that has neuronal differentiation, something that we do frequently and is advised in these primitive tumors is to exclude rhabdoid neoplasms. This is INI1. You want to make sure, particularly in very young children, that INI1 is retained. And that's the case here. It's strongly positive in the nuclei. It tells you that it's not a rhabdoid neoplasm. GFAP. In this case, it's negative. So the embryonal tumors can express also glial markers, but to a limited extent. And here you can see that the GFAP here is negative. This is Ki67. Embryonal tumors, almost by definition, tend to have these very brisk proliferative index. We're seeing it here, at least in areas. They can have better differentiated areas, as we're going to see in some subtypes, but for the most part, you want to see a lot of proliferation in the embryonal tumors. So we have everything for an embryonal tumor involving the posterior fossa. So presumptively, a diagnosis of medulloblastoma will suffice at the moment. As we saw earlier in the classification, you have many different subtypes. So next, we want to try to subtype it. If we go back to the morphology here, you can see there is a bit of nodularity. So it is something that you can consider here, and it was my first consideration, is a nodular desmoplastic variant at the histologic level, which almost always corresponds to the Sonnich hedgehog activated subtype at the molecular level. So that was my presumptive diagnosis here. We did a panel of stains for further subtyping as a first pass. This is beta-catenin, and you see it's all membranous, which is a normal result. That kind of excludes, for practical purpose, the Wnt subtype. It's important to recognize since it has a better prognosis. So in the abnormal cases, you're going to have nuclear beta-catenin staining, but here is cytoplasmic and membranous. We also did GAP1 and JAP1, which were negative to my surprise, because again, I was favoring a Sonnich hedgehog activated tumor. And it was sent for methylation profiling and also chromosomal array and other molecular testing, since the child was being considered for a clinical trial. And actually this match as a medulloblastoma non-Wnt, non-SHH, and more specifically to the molecular group 4 by chromosomal alterations in some ways, infer it, place it comfortably in the non-SHH or non-Wnt, and then methylation profiling classified as a group 4. This is a image that is shared a lot in many conferences. You might have it, that summarizes the different molecular subclasses that are agreed upon for medulloblastoma, which are the Wnt, which has the best prognosis. As I mentioned, you can identify it by the presence of beta-catenin mutations. You can sometimes use the immunohistochemical surrogate when you have good nuclear staining. It can be focal sometimes, but it recognizes the Wnt subgroup, has the best prognosis. You have the Sonic hedgehog, which has an intermediate prognosis. It has a variety of alterations that allow activation of that pathway, and it corresponds histologically to the nodular desmoplastic. So most nodular desmoplastic will fall in this category. But sometimes you have tumors that are just classic histology and still will fall there. Then you have the group 3, which have MYC amplification. Has particularly when MYC amplification is present, it's associated with the worst prognosis. And then you have the group 4, which is your conventional classic medulloblastoma. And that's where this particular case fell into. Now, we had some nodules, so that is something that that was a little puzzling, but the desmoplasia was not very accentuated. And this is something that has been highlighted in the literature. Particularly David Ellison has discussed this and have termed these this group of tumors as biphasic tumors. These are tumors that tend to have some nodules or pale areas, but the desmoplasia is not very accentuated. And in that context, these can still fall in the classic subgroup. It's a subtype of a classic subgroup, and then some of these will go into group 4 predominantly, or group 3. So something to have in mind. You can reticulin, we can use it sometimes to highlight the desmoplasia. You can have a little bit. This one had a slight tiny bit, but the conspicuous desmoplasia with very nice, well-formed nodules that you see with nodular desmoplastic were not completely present. And you see here the immunohistochemical subtyping followed by molecular was very helpful. The next case is a 5-year-old girl with a posterior fossa mass. So we have a theme here. Okay, another primitive neoplasm, very cellular, cells packed together, a lot of necrosis and scattered apoptotic bodies. So apoptosis was easy to identify in this. And this is a higher power field. Mitosis easy to find. Something also that you can start noticing is that the nuclei are a little larger compared with the previous case, for example. And that is something concerning in medulloblastoma. That is usually when you see uniform enlargement, and that defined maybe as 3 times, the size of a red blood cell, about uniformly. That is one of the criteria for the anaplastic subtype of severe anaplasia in medulloblastoma, which is a poor prognostic sign. That's what we're seeing here. Let me see something. This is reticulin. and you have a slight increase in reticulin deposition, some vague nodularity. Synaptophysin staining, which confirms the neuronal phenotype. This is JAP1, which had some staining. It's not the strongest, but there was some staining in tumor nuclei in addition to vessels. So this was JAP1 positive, and also had some GAP1 positivity as well. And these tumors that have some nuclear enlargement, something that you don't want to miss in particular is ATRT. So here you have the INI1. So it's not an ATRT, has a neuronal phenotype. So we're back in the position of a medulloblastoma, trying to look for a specific subtype. But we had JAP1 and GAP1. So most of the tumors that have, of the medulloblastomas that have an aplasia, severe anaplasia, the predominant molecular group is actually group 3 with MYC amplification. That has been reported for a number of years. But there are some also poorly prognostic subgroups that may be associated with anaplasia. And one of them are the Saanich hedgehog that have p53 mutations. And this tumor had belong to that category. Histologically, was of the severely anaplastic type or the anaplastic subgroup, but here we reached that pathway by the presence of p53 mutation in the context of a Saanich hedgehog. So as you see in the WHO classification, Saanich hedgehog is one particular subgroup, and then you further subdivide those with the ones that have the presence of p53 mutations and those that lack it. This one had very strong p53 staining, so that sometimes is a useful surrogate when it's strong. Doesn't cover all the p53 mutations and probably has to be confirmed by sequencing if possible. But this one belongs to this category, which has a very bad prognosis, and it's something important to recognize. Next case is another 5-year-old boy with clumsiness and difficulties walking for several months, and the MRI demonstrated a large cerebellar mass. And this is a tumor. And you can again start seeing frequent mitotic activity, some apoptotic bodies, a slightly peculiar nuclear elongation, but not really enlargement as you see in anaplasia, maybe some ganglion cell differentiation, something very curious there. Kind of delicate background, probably corresponding to neuropil. So we are again in the camp of medulloblastoma, being in the posterior fossa and having an embryonal tumor that had morphologic and immunohistochemical evidence of neuronal differentiation. And we further proceeded with phenotyping in this case. And this is the beta-catenin. And you can see obvious nuclear staining. You see it's not throughout. It's not always throughout. You can have it focal. So you have to be very careful when reviewing beta-catenin staining. Sometimes this one had convinced me. It did have, in some areas stronger than others, had the nuclear staining. that we are looking for, which is reassuring because this is a surrogate marker for the Wnt medulloblastoma subtype, Wnt activated subtype, which is associated with the best prognosis among the standard medulloblastoma subtypes. So this is Wnt activated. They're still considered a WHO grade 4 as embryonal tumors are, but it's certainly associated with a much better outcome over time and a higher chance of cure after treatment. Next case. It's case number 4. 4-year-old boy presenting with seizures and a right temporal lobe mass was discovered. So we're moving out of the posterior fossa and into the supratemporal compartment where many of the new entities have been increasingly described. This is the H&E, and we can see this is a very cellular tumor. Composed of round cells. In areas you can argue, well, they look a little bit, the chromatin looks delicate, it looks a little bit more benign appearing than the tumors I've shown you so far, but it does have frequent mitotic activity. That's that type of mitotic activity is incompatible with a benign diagnosis in this context, even though the nuclear features are a little bit more favorable. It's cellular enough and has this increased proliferation. So this allows you to place it into the embryonal category. It's not a neurocytic tumor. It will be something to think about, something neurocytic. We do see a variety of neurocytic neoplasm, extraventricular neurocytoma, etc. But this one has too much proliferation for that, even though the nuclei look somewhat bland. You also get a feeling that there is neuropil in the background, which is this very delicate eosinophilic stroma. This is OLIC2. And OLIC2 we use it many times as a marker of glial tumors, infiltrating gliomas and other glioma subsets. But it's also positive in many subsets of embryonal tumors. So it's not a marker specific for glial differentiation in contrast to GFAP. You see it frequently in gliomas, but you also see it in various subsets. And it's helpful in the differential diagnosis of several categories. This tumor happened to be very strongly OLIC2 positive. We also did INI1, which we do frequently in the pediatric population. And you see this here, and at first glance you say, well, is it lost because it's very weak? And something that is important to know for these surrogate markers, particularly the ones that are where loss of the marker is a positive result, you need to have good internal controls. You want to make sure that the reaction work well, because fixation and other poor tissue quality can affect it. So this one, you can even go into the equivocal category, but moving around, you start seeing areas that are better fixed in which the tumor cells are positive. So this was just a poor immunostaining result, and you have to interpret it with a lot of caution. That goes for INI1, ATRX, H3K27 trimethylation. Those are markers in which a negative result is very important. And it's the positive result, really, negative lack of labeling. and you want to make sure that you have good internal controls. So here was interpreted as preserved. And here further molecular testing was done, and the tumor fits into this category, which is being incorporated now in the WHO classification as CNS neuroblastoma, FOXR2 activated. So in the past, many of these tumors will be placed into the PNET, supratentorial PNET category, or CNS neuroblastoma without any other designation. And we know that many of these, this is a specific category, particularly when they have these alterations in FOXR2. This is an embryonal neoplasm with variable neuroblastic and sometimes even overt neuronal differentiation. FOXR2 is activated here by various structural rearrangements. They tend to express OLI2. Sometimes they express TTF1. This is something very important to have in mind, because when we see round blue cell tumors in the CNS, we always many times want to exclude metastatic small cell carcinoma. That is more an issue, of course, of adults. This is a tumor type that affects the pediatric population. So if you have TTF1 here, actually is not unexpected. It can be very strong, actually, in cases, in a high Ki67 proliferative index. Those are some practical points that it's important to have in mind. And there is here another case I wanted to share with you. Another primitive case, primitive embryonal neoplasm. Round blue cell tumor. But with better differentiated areas in the form of ganglion cells. So ganglioneuroblastoma is the term that we use in the past for these. We can still probably use it at the morphologic level. You do have embryonal components and you have well-differentiated ganglion cells. And some of the FOXR2 type tumors, embryonal tumors, have this morphology. So the ganglioneuroblastoma, they can have other alterations as well, but the FOXR2 subtype can have either round blue cell tumor, poorly differentiated tumor type appearance, can have cerebral neuroblastoma type with nodules, a lot of neuropil, and or some of these morphology with ganglion cells that we have termed in the past ganglioneuroblastoma. Just something else to have in mind when looking at them. So how these supratentorial groups have come about? This is one of the a historic paper that came a number of years ago, trying to clarify by comprehensive profiling many of these categories known in the past as CNS PNET. Now that the term PNET has disappeared from the literature or from the classifications, rather, and the term replaced with the term embryonal. And they did a comprehensive staining profiling of many of these tumor, and they found some of them will cluster known entities at the time, but there were also other groups that were novel groups that were found. And some of them, this is where the CNS, the neuroblastoma FOXR2 came about, and a better differentiated neoplasm. You can see here a spectrum of differentiation, even areas that look a bit more neurocytic. Then there were the tumors that were placed into the mesenchymal or round blue cell category. The tumors that had MN1, some of these now have been placed into more of the glial categories, and the ones that have the B core, so alterations. So a lot of these categories now incorporated into the WHO in different sections were initially identified by very comprehensive molecular testing, and this is clinically relevant and is used a lot now for clinical trial decisions. Case number 5 is a 1-year-old boy with fever, vomiting, and developmental regression. And this is the MRI, which showed a horrible mass involving the supratentorial, actually the suprasellar compartment here, extending into the ventricles. So very poor presentation for a brain tumor at this age group. So it's further frustrating because these patients are usually cannot receive radiation. The radiation has a very negative impact in the developing brain, particularly in the first couple of years of life. And with very few exceptions, they try to avoid it if possible. And these are the sections. This is kind of aspirated material with fragments of tumor. Also a tumor that appears primitive, very cellular, proliferative, but some subtle differences with some of the tumors I've been showing so far is that cells tend to have a little bit of more cytoplasm. Some of them, that cytoplasm is eccentric and eosinophilic. So primitive neoplasm, very young patient. High grade. Again, here and here. Another inclusion there. Let's move around a little bit. Get a better feel for it. There we go. And here you have these cells here that should start making you think in a particular direction. Eosinophilic cytoplasm, eccentric. All right, so we knew we were going in a specific direction here. And did some immunostains, very limited immunostains. We had limited material initially. And this is the first stain that we did, which was the INI1. And to our surprise, it was preserved in tumor cells. So this was a very good result, good immunoreactivity, no question that the tumor has retained INI1 expression. So we were slightly puzzled, but then we now know that there are other possibilities here. And we added BRG1. And there was loss of expression on it. Here you see that the tumor cells are negative, and the non-neoplastic cells and vessels and other stromal elements are positive. So this is BRG1, or product the antibody recognizes the product of the SMARCA4 gene, which is actually mutated in a small subset of ATRTs. So this is a relatively unusual finding, but still compatible with the clinical pathologic scenario. So this was, we still call it atypical teratoid rhabdoid tumor. It's the same category, grade 4. So what we know about these tumors, we know that what ties them together is loss of one of these INI1 or BRG1 expression. That's how we recognize it at the pathologic level or confirm the diagnosis. That is required for the diagnosis, even though it may have the classic morphology, the classic rhabdoid morphology, you really need to, it's one of those first categories that required molecular confirmation in the WHO, and that was back in 2016. So it's important to be able, other than that, you can still call it rhabdoid. You have a spectrum of rhabdoid tumors, but you really need to document for the diagnosis loss of one of those two components. We know more about them now. There is being large-scale methylation and comprehensive gene expression profiling of these, and the tumors encompass 3 different categories. There is still some debate whether some of these do worse than others, but they're being used for clinical trial enrollment and the testing of novel chemotherapeutic agents. This is a very aggressive tumor, so any advance in our understanding is helpful. So this is not required for the diagnosis. It's not that this doesn't separate it for the diagnosis or for WHO classification, or for standard treatments, but it's something that we are doing more and more with different tumor types, including ATRT. So ATRT is a poorly differentiated neoplasm, part of the spectrum of INI1 deficient tumors. It is defined, it has to have B allelic inactivation of SMARCB1, which you recognize with the immunostain for INI1, or inactivation of SMARCA4 or BRG1, which happens in approximately 5% of the cases. Something to have in mind, some tumor that may have classic ATRT appearance and still has retention of INI1, it's important to think about the next step, which is BRG1, or many times if the lab has it, this can be done concurrently for time's sake. Now, one message here is also that no single marker recognizes is diagnostic of any tumor type, and INI1 loss in particular, we have been learning that isn't. Any tumor in the past that had INI1 loss, we were tempted many times to put it in the ATRT category, but we're starting now learning that there's a variety of tumors that may have INI1 loss and they are not ATRTs. CRENET, cribriform neuroepithelial tumor, has been incorporated in the 2021 WHO, and it does have this very peculiar morphology. Cribriform, as the name implies, cribriform ribbons, almost more epithelial looking, and they tend to have INI1 loss. They consistently have INI1 loss. They may even group by methylation profiling with some close to some of the ATRT subgroups, but these are considered tumors with a much better prognosis. So even though they are considered to be part of the embryonal category, they still do better than ATRT. So it's one of those categories that is important to separate when you see them, despite of the perfect INI1 loss that you encounter. There's also other groups. One of them is a peculiar tumor type that occurs in the pineal region that has been also incorporated in the WHO, the desmoplastic myxoid tumor, SMARCB1 mutant. And these tumors have a variety of myxoid areas, desmoplastic areas. They tend to be more on the low-grade side and to have a better prognosis compared to ATRT. So something also important to recognize. And even more recently, this was after the WHO was published clarified. There's other tumor types that may have some tissue infiltration, may have a very low-grade morphology, and have also INI1 loss, have a better prognosis, but still occasionally cluster, have some epigenetic similarity with ATRT. So this is an expanding field. You're going to start seeing a variety of morphologies, even independent tumor types that may have INI1 loss. So you want to have everything together to be able to make that diagnosis. ATRT is a very serious diagnosis to make. You want to make sure that everything fits from the pathology to the phenotype, and then confirm it with the INI1 or BRG1 loss. Okay, another case, 2-year-old girl with right hand weakness and left-sided twitching. This large mass involving the hemisphere, relatively well circumscribed, but large with mass effect. And something very interesting here, they're seeing that this is after contrast. This has very little in the way of contrast enhancement. This is actually very characteristic of this tumor type. And here we have another cellular neoplasm with a lot of apoptosis and mitotic activity. High grade for sure. Embryonal appearing for sure. So the next step is to make sure that we classify it in the proper manner. Or look around. This one actually was a large resection. And we started seeing areas that look a bit more hypocellular, interspersed with those proliferative regions. And this is something actually is a very good clue for it. This here is part of the mass. This is not normal brain. This is part of the mass actually. And you have a lot of neuropil there. Almost resembles non-neoplastic brain. Neurocytic appearing cells. Better differentiated regions. And you start seeing here a clue. This is kind of falling apart a little bit, but you can envision that this is actually almost a lumen of and composed of with a wall composed of these primitive cells stacked on top of each other. And this is actually a multi-layered rosette. See something here as well. Almost resemble an ependymal type of rosette, but it has a lot of primitive cells in the wall and a lot of proliferation in those. That is very typical for these multi-layered rosettes. Another one there. Okay. So as far as stains go, let's see, we had some OLIC2. Which was positive in subset of these cells. Not everywhere. INSM1. And INSM1 is a marker that we like to use for neuronal differentiation. We apply it to the brain. And something that is interesting about it is that most of the markers that we see for neuronal differentiation tend to be stronger in well-differentiated lesions. So poorly differentiated tumors may lack some of the neuronal markers. And occasionally in some tumor types, the INSM1 can actually highlight the more primitive elements. So it's something that we like to use in combination with other markers, but it is a useful marker for neuronal differentiation when taken in context. And you see some of the more, looks like denser, more primitive areas are have more positivity in this particular case. See it here. Synaptophysing here is very strong, and you can see it all around, not only in the tumor cells, but also in these areas of neuropil that actually are so distinctive and give the tumor, used to give the tumor one of its previous names before it was renamed. Some areas more primitive don't stain with synaptophysing, but the neuropil does. So very useful in this context. And of course, I91 was retained. So this is an embryonal tumor with multilayer rosettes, or ETMR, WHO grade 4. So there's a variety of morphologies that have been associated, that are included now in this category. One of them is the etanther or embryonal tumor with abundant neuropil and true rosettes. That was the historic name. That was kind of, that actually that's the most common morphology that we see associated with this tumor type. Embryonal in the past, another term that kind of fell in disuse, and medulloepitheliomas. And we still see sometimes tumors that have this morphology and actually end up being in this category when the molecular alteration can be confirmed. So they are felt to be now part of the same entity. They are in the WHO. So, and then you have tumors that don't have any of those patterns, but look like an embryonal tumor NOS and have this amplification of this microRNA cluster in chromosome 19, and actually will fit into that category as well. So patients usually are young, less than 3 years of age. These tumors are predominantly supratentorial, but they can affect the posterior fossa, and that's something to have in mind, that having an embryonal tumor in the cerebellum doesn't automatically make it a medulloblastoma. You can have other distinct categories that can occur in the posterior fossa compartment. Leptomeningeal dissemination, extraneural metastasis can see in later phases of the disease, and it's a really highly aggressive neoplasm with a bad prognosis. Molecularly, this was the alteration that was detected in the past, and that is relatively specific for it. There's this amplification of the long arm of chromosome 19, focal amplification of this microRNA cluster, can be detected by a variety of techniques, array-based techniques in fish. But there is some with increased profiling, you start seeing the exceptions. There are tumors that have this specific morphology or that fit into this category by methylation profiling, but lack this 19 cluster. And one of the alterations that have been seen in some of those cases are DICER1, which are frequently germline. So if you see this tumor and you profile it and you find that there's DICER1 mutation, have to be concerned that this could actually be a germline mutation. So it's part of the DICER1 related group of tumors. And then you have rare ones that have other type of alterations. So something that I want, before we move on, want to show you another example of a more classic morphologic type here. This is something that we call medulloepithelioma, which can happen in a variety of sites. When happening in the CNS as a primary CNS tumor, it tends to be part of this ETMR group and frequently have this C19 amplicon. There are some that occur outside of the CNS, and then some that occur in the eye. So that probably represent different molecular, they have represent something different, but you recognize it as tumors that have these resemblance to the developing CNS neural tube. So that is how the term came about, but probably you have other category of tumors that fit there. It's not a distinct category anymore, and the WHO is considered more of a pattern, and to be placed into the ETMR if you can document one of the characteristic alterations. All right, so let's review some of the other embryonal tumor types that have been discussed recently in the WHO. One of them is the CNS tumors with B-core internal tandem duplication. These are high-grade tumors, tend to occur in the hemispheres. They frequently are necrotic and have brisk mitotic activity, so they are considered high-grade. And the necrosis can be pseudopalisading, so it can be technically misinterpreted for glioblastoma. And they have this very strong B-core immunostain pattern. It affects pediatric patients, so it's important to note. Occasionally, we have tumors that have this a funny pattern and maybe some B-core staining, and we get referred to into stating, is it in an older patient, and actually this tends to be more a pediatric type of tumor. It's important to have those age contexts in mind. High-grade tumors, they have frequent recurrences. Although the prognosis is still being debated, given that there is a rare neoplasm. You tend to have on occasion these ependymoma-like pseudorosettes, which makes you think about ependymoma. And it's important to know that the alteration, these are tumors that have B-core ITDs or internal tandem duplication. This is a specific type of alteration. It is different from those tumors that have B-core mutations, which are many, and it's a bit less specific, or fusions. Now, we reach a point now that we're seeing a lot of categories that are now being defined or by their molecular alterations. And of course, we don't always have enough tissue or the technologies available in our laboratories to do all these comprehensive profiling. So it's something to have in mind. There's still room in the WHO for descriptive diagnosis. I mean, so if we can put it in the CNS embryonal tumor category with a panel of stains, you have done a lot for the patient. And in some cases, the only thing you can do is try to exclude categories with a comment, and that many times suffices. So the CNS tumors that are NEC or NOS arise in the CNS, embryonal morphology, you want to confirm it by immunophenotype. You want to make sure that this is not a glioma or some sort of round blue cell tumor. We're seeing increasingly also with time, mesenchymal round blue cell tumors that are more considered soft tissue entities presenting as primary CNS tumors, not only in the dura, but actually in the brain parenchyma itself. So it's something to have in mind. You can have rhabdomyosarcomas, you can have Ewing's, you can have all those tumors present as primary parenchymal neoplasms. It's something to always to have in mind. Not elsewhere classified is something that is allowed in the WHO by tumors that lack, after comprehensive profiling, you find you do all the diligence and to looking into a specific type, and it lacks specific alterations for a tumor type, but you still want to keep it in the embryonal morphology. Many times these are emerging entities that eventually will become separate entities on their own, or really something very rare or an outlier. Then you have the not otherwise specified category, in which the tumor is not susceptible to further analysis. Maybe tumor in which you don't have testing for all the different alterations that are required for the classification into one of those subtypes we discussed, or the material that the block is exhausted, but you still feel it's embryonal, and you can place it in this NOS category. And this is an example. This is a tumor that we profiled thoroughly, but it looked to have a primitive appearance, round cells back to back, frequent mitotic activity, young patient, and we can put it in the embryonal NEC or NOS, depending on the extent of workup that has been done. All right, so I'll leave it here for, I'm gonna go over some questions, quick questions. Which of the following markers help in recognizing the medulloblastoma subtype with the best prognosis?
I'm looking at responses from the viewers. Let me keep an eye on it. I see some of our viewers opting for A, and let's see if there is more. Yeah, there is more options for A, that is beta-catenin.
And that's correct. So beta-catenin recognizes as a good, useful surrogate of the Wnt activated subtype of medulloblastoma. It's not perfect. It can be focal. So if you have a strong suspicion, you always have can follow up with other markers. They tend to also have monosomy 6. It's another marker of this subtype. So have to be very careful that and make sure that your stains are working and that they can be focal and they can be occasionally missed. So which of the following is associated with a bad prognosis in SHH, Saanich hedgehog activated medulloblastoma?
All right, we will give a couple of minutes and just see. I think there are answers for E, that is P53 mutation. More of our viewers are opting for the choice E.
Fantastic. I think we're paying attention. So yeah, p53 mutation is associated with a worse prognosis, and it's a separate category within the WHO. So it's important to recognize. Oftentimes, these patients have the tumors have anaplasia or some other worrisome features that cannot trigger your pick your interest. But yeah, the idea is sometimes this can be detected. P53 is not the perfect surrogate, but if you have very strong uniform P53, that probably can be followed with sequencing. Which of the following alterations may characterize a subset of embryonal tumor with multi-layer rosettes?
Okay, just a couple of seconds so that we can see the responses. Oh, so it's coming for A, and let us see what more we have. I think, yeah, more of A is coming. That is DICER1 mutation. Yeah.
That's the correct answer. So it used to be the most common alteration of these tumors are these amplicon and C19 and this microRNA cluster. But there's a subset of tumors that have, instead of that, they tend to have a DICER1 mutation, which is frequently germline. So it's important not only for tumor diagnosis, but probably for family counseling as well. And the final question, which of the following alterations characterize a new embryonal tumor subtype in the 2021 WHO classification?
Yeah, this is the last question. Let us see. I think, again, our viewers are probably going for A. There is more of A coming up. There is B or ITD. Yeah.
And that's correct. So that is a group. So you can have BCOR mutations in a variety of brain tumors. They play a role, but what really recognizes this separate subgroup of embryonal tumors is this ITD mutation. And then you have alterations that recognize other groups of tumors, but that they are not necessarily that recently incorporated. This is a really new entity in the WHO classification of 2021. And those are the questions that I had, but actually, if you have other questions, I'm happy to stay on and try to answer, or comments or suggestions.
Yeah, thank you, Dr. Rodriguez. There are some questions that I see online, but before that, let me quickly go back and inform our viewers regarding how to get the CME code on the CME credit. And as the viewers, you know by now that I have shared the CME code on the chat box. And what you can do is that to get the CME credit, you definitely need to create an account at the City of Hope CME Center. And if you have already done that, and if you are watching from the United States, you can definitely text in the code to this phone number on your screen. And for our international viewers, so once you have created an account, you can email the CME code to this cme@coas.org. That is the email address. And please make sure the code will expire soon after the live lecture. So please send it now. We still have a few minutes during the Q&A session so that you can share the code. And you will receive an email from City of Hope requesting feedback to evaluate the talk and the CME activity. And please submit the evaluation within 1 business day so that that will complete your CME activity and you will get the CME certificate. And with that, so let me share the questions for Dr. Rodriguez. Dr. Rodriguez, the questions that I found, one question from one of our viewers is, I will read it for you. So anaplasia or large cell morphology might be focal sometimes. How do you interpret these cases? Is there any cutoff in percentage? As far as I know, this would put the patient into the high-risk therapeutic group.
That's a very important question to have. So anaplasia, it has to be present in many fields. You know, we are looking at diffuse anaplasia in probably multiple fields. There have been some criteria that some publications have put in the past, but as far as finding a small focus of anaplasia, you may want to put a comment on it. Of course, it's not something to completely pass through. You know, as long as it's really looking at this nuclear enlargement and the other features that are described, a lot of cell-to-cell wrapping in association with that, proliferation. But you want to see it more because you want to put the tumors in the category of the anaplastic large cell category. So sometimes we write some reports in which you say there's some degree of anaplasia, but this is insufficient to place this particular tumor into the anaplastic category subset, and you keep it in the classic or nodular desmoplastic or one of those. So it's a focal, it should not suffice for it.
Right. Thank you, Dr. Rodriguez. There is another question. I'm not sure exactly what our viewer wanted to know, that what is the histological response time in your clinic? So I don't know what exactly does that mean.
Yeah, that varies, right? I mean, some of these tumors that I'm showing you today, maybe I need to spend a little bit more time with. You need to do specialized stains, specialized molecular testing. I tend to release many of my reports before we get all the molecular back, because sometimes it can take significantly longer, particularly if you have to add things like methylation or something along those lines. So, I think the standard case, you may see the frozen section the first day, and maybe a couple of days later, you are able to get your permanence 1 or 2 days later. Do your panel of stains, or 2 or 3 days for a standard case. But if you really need specialized immunostains and molecular testing, that will take significantly longer. And I think that's the situation with many more and more we're encountering.
Right. So the next question is, I think, something related. How can you exclude a pediatric type high-grade glioma without molecular?
I assume that you're still able to do immunostains, right? So a pediatric type, can you repeat the question on a pediatric type diffuse glioma?
Yeah, pediatric type high-grade glioma without molecular. Yeah.
So you have to start thinking about there's specific categories that you can get clues for, first with the clinical pathologic scenario, and also with immunostains as a second pass. So let's start with the clinical. So if you have a tumor that is really involving a midline structure, expansion of the pons, or something along those lines, that's something that embryonal tumors tend to do less. You do have a very exquisite infiltration of the midline structures. That is that just by the description, it favors as going to be one of these H3K27 altered tumors. So it's a very strong likelihood that that's what's going to happen. So there, even if you have a little bit of an embryonal appearance or a little bit of synaptophysin staining, you still have to either exclude those or start thinking that it's actually a strong likelihood. Then there's a specific category of diffuse type of high-grade tumors in children. So then you have the ones that occur in the hemispheres. And now you have the G34 mutant tumors that occur in the hemispheres and occur in young patients, not only children, they can occur in young adults. And frequently we see, actually, I've seen it more in young adults actually than in children, the histone G34 mutant tumors. They can look embryonal. So one of the characteristics of it is that it looks embryonal. But when you start going to stains, the GFAP is strong, the synaptophysin is iffy, is either negative or weak. And something that is very also characteristic of it, they lack OLIC2 positivity, and they have loss of ATRX. When I see that combination, it's my very first consideration. And there are immunostains even for the G34 mutant tumors. I don't have it. I don't use it. I usually proceed for sequencing when I suspect it after the panel of immunostains and suggesting it. But that is another category of tumor that you can really see by just a basic panel of immunostains or suspect. So you have the histone H3K27, the histone G34, and then you have others that you have these infantile type, which is another type of high-grade diffuse glioma. Those occur in infants. So if you have something that really looks, and they tend to look very much better differentiated, they don't tend to look embryonal. So they look more like gliomas, just that they occur in very young patients. And when you have those, then you have to start suspecting the infantile type. diffuse gliomas that frequently have these oncogenic fusions. They have ALK, RET, or something along those lines. So that's basically covers most of the specific categories that you see in the WHO. But of course, you have the rare exceptions and other rare alterations sometimes.
All right, thank you, Dr. Rodriguez. So there is another question. What is the utility of INSM1 in CNS neoplasms?
Yes, so I will see it as another marker of neuronal differentiation. If you use it in general pathology practice, you see that it's helpful because it is a transcription factor, and it's nuclear. Or yes, it's a nuclear. It gives you a nuclear immunoreactivity. So you see synaptophysing. The CNS can be problematic because you do have entrapped axons. You have underlying parenchyma. It's the same situation between OLIC2 and GFAP. GFAP is relatively specific, has good sensitivity, but sometimes it's difficult to point it out to a specific cell since you have a lot of GFAP positivity in the stroma, and OLIC2 is a transcription factor, so that was very helpful when it came about. I see it in the same line between synaptophysing and INSM1, with the idea that not all tumors with neuronal differentiation will have it or express it. And when you have positivity, you can have some limited positivity in some gliomas. We had actually a paper a number of years ago on looking at different tumor types in the CNS that outline some of these issues. And I also see something that I see that can be very helpful and highlighted in one of these cases is that the areas many times that are more primitive, that are less differentiated, oftentimes can have INSM1 positivity and lack expression for other markers, for example, NUN, chromogranin, etc., which recognize the more well-differentiated areas. So this is all relative. It's not 100% for each case, but I use it as another type of neuronal marker. And when it's strong and very positive, it's very helpful in supporting a neuronal phenotype.
All right, thank you again. And the next question, I would like to read it for you. The modalities of treatment, are there in concordance with those different types of tumor? Are they versatile or still low concordance? I'm not sure if I could read it properly.
Yeah, I'm gonna do my take the step to try to interpret as I see whether if this has affected therapy, right? I mean, we have all these categories, and you may say, well, yes, fans, you're looking at all the genes that are altered in the specific tumors, classifying these tumors by it, but is that really driving treatment? And for sure, it's driving clinical trials. So if you go to a large center, that see a lot of pediatric tumors, there are large centers throughout the world, they would like to have that information because they are designing these trials for different subtypes. Even the medulloblastoma, I show you the ones that are now in the WHO as recognized as standard, but there are even multiple subgroups actually that are being outlined, and in the trials that's driving clinical trials. So in that context, it has usefulness. Now, do you have, depending on where you're setting, if you're in a smaller practice or in a practice that don't have all the tools, do you need to go over each alteration that you have? Maybe not. Maybe if the patient, decides to go to a large center to enroll in a trial, maybe they will probably try to do that eventually. So you don't have to, I'll say depending, you have to be very conscious of the setting in which you're practicing, how your local neuro-oncologists are using that information, because sometimes they give you the drugs may be the same. The chemotherapy are standard, and for many tumor types, for sure for the gliomas and for the adult population, you have very limited options. You have, particularly at first diagnosis, so you get standard chemotherapy or radiation, and then you have other chemotherapeutic agents that can be added, but many times these are after first line therapy or after for a clinical trial purpose.
Right. I think these are the questions that I found online, Dr. Rodriguez, for you.
Okay.
And would be very happy to hear, Dr. Rodriguez, that the viewers have joined from so many different countries. At least a couple of hundred viewers have joined online, and I could see that they were from as far as Ukraine, Nigeria, Vietnam, Mexico,
Right.
Italy, Kosovo, Nicaragua, Algeria, Malawi, Zimbabwe, to name a few. and they are all very appreciative of your talk, and they have commented about compliments for your excellent.
Oh, mm.
And thanks to our viewers for your support. And if you like the lectures, don't forget to subscribe to our YouTube channel and follow the Facebook page. And you can also visit our website to watch all the lectures. And Dr. Rodriguez has planned actually to have a series of talks and on these updates that he has called for the CNS tumors. And the next one will be on mesenchymal tumors, and we will announce the date soon. And our next lecture is coming up. So that would be on grossing, so which is very important, especially for trainees who have just joined pathology in different parts of the world, and especially in the US too. The new pathology residents have joined on just this July, and wish you the very best. So that's why we have decided to have a talk on key concepts in specimen grossing, which you would see is very, very important. And our speaker is none other than a pathology assistant who are excellent in doing grossing, and they are well trained. So he is Dennis Strang. So this would be his third talk, and he works as a pathology assistant at Wisconsin Medical Laboratories. And the talk is on August 9, 2022 at 12 p.m. Eastern Time. Hope to see you then. And thank you again, Dr. Rodriguez, for this wonderful talk. Thanks a lot.
My pleasure. It was wonderful to present with you.
Thank you.